Hey everybody, welcome back to the ECG channel. My name is Reed. Don't forget that you can download the PDF of this document down in the description below and you can follow along with me. And don't forget to like this video and subscribe to the channel if you enjoy this content. So let's get started. So this is a really cool ECG. I'm really excited that I came across this one. And so let's start off by looking at the forest. The trees of the forest are my QRS complexes. And so if I start down here in V5, you notice that we've got this pattern, right, where we have narrow, narrow, wide, narrow, narrow, wide, narrow, narrow, wide, right? So we've got this pretty regular pattern, right? This is a very irregular rhythm, but it has a regular pattern to it. And so let's try to figure out what is going on. So I've got these narrow beats, right? And you can see I've got P waves before the narrow beats. And then what you'll notice is that my early beat is a little bit of a wide complex beat compared to my narrow beats. Okay, so my first suspicion is that these might be premature ventricular complexes that are occurring every third beat. And so I can do a quick investigation, right? First, I notice that my other QRS complexes are nice and narrow with P waves before them. The P waves of those narrow complex QRSs, if I look closely, the P waves are upright in lead 1, and they're upright in AVF, so we do have sinus P waves, okay? So we have sinus P waves, and we have QRSs that are narrow, so that makes me think that those P waves are being conducted via the His-Purkinje system, right? We know that the AV node is what has to conduct those QRS complexes, and I look really closely, and I see that in my first kind of grouping of these beats, you can see my PR interval is long, right? My PR interval should be within 200 milliseconds. I would say this is maybe 8, 9 millimeters. So that's a PR interval of 360 milliseconds. It should be, right around 200 or less. So that's interesting, right? So we have an increased PR interval. So we have some type of AV block. What's even more interesting is the next beat that occurs. Look at the PR interval in this beat, right? PR interval is growing. So this one, my PR interval, is maybe 12 small boxes. And so that is 480 millisecond PR interval. Well, what type of AV block exists when the PR interval lengthens and lengthens and lengthens with every single beat? That's usually we see in a second degree type 1 AV block is usually when we see a PR interval that is changing, it is increasing every single time. And so now we're trying to worry about, is this a second degree type 1 AV block? Well, we know that at some point in a second degree type 1, we need to have a P wave that drops a QRS complex, right? But we have these early beats here that are getting in the way. And if you look at those early beats, they're wide, complex beats. And I think they're a premature ventricular contraction, but I need to make sure that there's not a P wave that occurs before them. And if I look really closely on the previous T wave and ST segment of these leads, I'm looking, I don't see any. So these are definitely premature ventricular contractions, right? These are all PVCs that are occurring every third beat, okay? So if you want to even be more specific, we would call this ventricular trigeminy. And so what we're actually seeing is we have the physiology of a second degree type 1 AV block where the PR interval is being lengthened and lengthened and lengthened, but we're not able to see when the P wave drops because of this ventricular trigeminy. So we would say that we have a second degree type 1 AV block physiology terminated with PVCs in a pattern of trigeminy, right? We would expect if this PR interval continued to lengthen, it would likely drop, but we don't get that here. So all we get to do is explain that we see that physiology of that second degree type 1 AV block, because we know second degree type 1 AV blocks are evidence of decremental conduction, if you haven't watched my second degree type 1 AV block video, I would go watch that. It's evidence of the decremental conduction of that AV node, right? And it's happening at baseline here, right? Because if you look, those R to R intervals really aren't that close, right? This is a pretty normal rhythm. 300, 150, 100, 75, 60, probably 65 beats per minute. We shouldn't see that decremental conduction, so we're definitely getting second degree type 1 AV block physiology terminated by a PVC. So that occurs pretty regularly. Well, let's evaluate the rest of our rhythm, right? Let's look at that normal QRS complex and see what happens. We've got a QRS that's upright in lead 1. It's upright in AVF. That tells me that my QRS, when it's depolarized via the AV node, is down to the left. So that's reassuring. We've got good R wave progression, right? You see my little septal R wave that grows, becomes more dominant here in lead 4, so that's good. I also look for any ischemic changes, right? We know that sometimes ventricular ectopic rhythms or beats like these PVCs can be because of some type of scarring or active myocardial infarction. And luckily, as I scan through the anatomical distribution of my ECG, right, we've got our high lateral leads, we've got our inferior leads, we've got septal V1, V2, we've got anterior V3, V4, and then we've got the other lateral leads V5, V6. I don't see any ST or T wave abnormalities that are concerning. And so we put this all together, and what do we have? We've got a sinus rhythm, and that sinus rhythm seems to generally be occurring at a rate of 65 beats per minute on average. We have evidence of second degree type 1 AV block physiology that is terminated by ventricular trigeminy. So I hope this video helps. I hope this helps you understand kind of the physiology of the AV node and things that happen in patterns, right? Anything that repeats over and over and over again. Start looking for, what could that be? And so have a framework, understand the morphology of the QRS complexes, and and you'll do great. So thanks so much for watching this video. If you have any questions, put them down in the comments, and if not, subscribe to the channel if you enjoy it. Hope you do, and have a great rest of your day. We'll see you on the next ECG video.